So hello everyone. So let's just have a look on the most important past year questions, NEET questions. So for the students who have attended their live class, followed the Bhatia schedule, so for them all these questions are an absolute cakewalk. So this is more of a revision kind of session. So let's just have a look on the first question, that is the granular cell type of ameloblastoma. The granular appearance is due to, okay, so the options here are lysosomal aggregates, mitochondria, amyloid secretory vesicles. Now this is a very direct question. Okay, so here the answer is lysosomal aggregates. Now just have a look on the other options. Now mitochondria, it is involved in the striated appearance in the striated duct of the salivary gland. Duct of salivary gland. Amyloid. So we all know amyloid, it is present in pinned box tumor. What is the different name of the pinned box tumor? Pinned box tumor. What is the other name of the pinned box tumor? It is CEOT, that is calcifying epithelial odontogenic tumor. Secretory vesicle, so you would have done this in DADH. It is important in the process of exocytosis. Okay, so here the answer is very direct, that is lysosomal aggregate. Now, let's just have a look on granular ameloblastoma. So, as a general rule, okay, ameloblastoma has a peripheral tall columnar cells. Okay, peripheral tall columnar cells, and in the center we have stellate reticulum like cells. Now, if metaplasia occurs in this stellate reticulum like cells, it undergoes different forms of ameloblastoma. So what do we see in granular cell ameloblastoma? Here in the stellate reticulum cells, there are granules are present in the cytoplasm of the granular cell ameloblastoma. So here again, this is the histopath. Lot of granules are seen in the ameloblastoma. Now, because of these granules, these are very aggressive form of ameloblastoma. Okay, so now let's just jot down all the important points. Okay, so here at periphery, we have ameloblast-like cells. Now, what are these ameloblast-like cells? These are tall columnar cells with hyperchromatic nucleus. Now, coming to the next point, if metaplasia occurs in this stellate reticulum-like cells, it will give, first is the acanthomatous ameloblastoma. So, what do we see in acanthomatous ameloblastoma? Squamous cells. That is, it is called as squamous metaplasia. The next is the basal cell. If the stellate reticulum like cells, if it will transform into basal cell ameloblastoma, granular cell, it will be called as granular cell ameloblastoma. Now, in the stellate reticulum like cells, the cytoplasm, it appears granular in the granular cell ameloblastoma. Now, what is this granules? How these granules are forming? Because of the lysosomes. So, these lysosomes, they condense to form granules, and these lysosomal aggregates, they release a lot of hydrolytic enzymes. Now, because they are releasing a lot of hydrolytic enzymes, it is very destructive in nature. Okay, so that is why granular cell ameloblastoma, it is called as most aggressive form of ameloblastoma. Now, there are 6 histopathological variant of ameloblastoma. It is very important. So, which is the most common type of ameloblastoma? It is the follicular ameloblastoma. Acanthomatous, it is the least rate of recurrence. Basal cell ameloblastoma, granular ameloblastoma, plexiform and desmoplastic ameloblastoma. Now, in what and all conditions do we see granules? So that is the first condition is congenital epilepsy of newborn, granular cell tumor, granular cell ameloblastoma as we have discussed now, and granular cell odontogenic tumor. So this will help you in the questions. Now coming to our next question. Now 8q12 gene is associated with what pathology? So here the answer is very direct. Okay, this is a very factual based question. The answer here is pleomorphic adenoma. Now, which is the most common salivary gland neoplasm? The most common salivary gland neoplasm, it is pleomorphic adenoma. Now, if they have asked most common malignant salivary gland neoplasm, then the answer is most common malignant salivary gland neoplasm. The answer is it is mucoepidermoid carcinoma. Now, the term pleomorphic, it has been described because it shows multiple morphologies. Okay, so we will see what and all different morphologies are seen. So, pleomorphic adenoma, which is the gene associated, that is PLAG1, and it is mapped to chromosome 8q12. Okay, so many morphologies are seen in pleomorphic adenoma. Now, why the many morphologies are seen? Because it has a epithelial structures which are present in the form of islands or duct. Along with it has a connective tissue. Now, this connective tissue, it is present in form of chondroid, osseous, myxomatous or the hyalinized area. So, in this diagram, it is very clear. Okay, so the epithelial part, it is present in the form of islands or the cords, while the connective tissue part, can you see all these hyalinized area, osseous area is present. Now, since it was seen that it has both epithelial and the connective tissue part, it was called as pseudo-mixed tumor. But actually, it is not a mixed tumor. Why? Because their origin is not from the germ layer. The tumor which gets its origin from all the three germ layer are called as mixed tumor. Example, teratoma. It is a true mixed tumor. Now, from where all these components are derived in the pleomorphic adenoma. So, all the components of the pleomorphic adenoma, these are derived from ductal reserve cells or the myoepithelial cells. Now, what are these? These are progenitor cells. These are not the epithelial and the connective tissue. Even the epithelial and the connective tissue, they will be derived from these two cells that are progenitor cells, which is present in pleomorphic adenoma. Now, coming to our third question. Of the following features are suggestive or poor prognosis of the tumor except, okay. So here the options are grade of the tumor, angio invasion, perineural invasion and inflammatory cells. तो अभी हम एक एक ऑप्शन देखते चलेंगे, ठीक है. ग्रेड ऑफ द ट्यूमर, ओके. It is a very commonsensical question. Grade of the tumor, higher the grade, poorer will be the prognosis. What is angio invasion? That is invasion of the cancer cells into the blood vessels. So if there will be invasion of the cancer cells into the blood vessels, obviously there will be more poor prognosis. What is perineural invasion? That is invasion into the nerve part. Obviously it will have more poorer prognosis. So which option is left? It is inflammatory cells. So answer here is inflammatory cells. Now, inflammatory cells. So, higher is the number of inflammatory cells, especially of the lymphoplasmacytic in nature, better is the prognosis. Now, let's just jot down all the points which we have discussed. Grade of the tumor. Higher the grade, poorer will be the prognosis. Angio invasion is the invasion of the cancer cells into the blood vessels, which point towards that it has a poorer prognosis. Perineural invasion, it is the invasion of the cancer cells around the nerve bundles, which points that it has a poorer prognosis. Coming to our next question, okay, and one of my favorite topic. Okay, so the patient had a periapical radiolucency around deeply carious tooth since many years. The histology shows epithelial lining the capsule containing the granulation tissue. Now histopathology shows this image. Which of these bodies is seen? Okay, now in the question it is very clearly evident that the tooth is deeply carious, okay, and along with there is a body. Okay, so if your tooth is deeply carious, that means they're talking about non-vital tooth. Non-vital tooth. And which body is seen in associated with non-vital tooth? So there comes to our most common cyst, that is the radicular cyst. So radicular cyst में कौन सी bodies दिखती है? It is Rushton body. As in this image, it is very clearly seen that these are tiny eosinophilic arc-shaped bodies which are seen in the lining epithelium. Now, this is the Rushton bodies and this is the Russell body. So your other option is Russell body. So let's just have a look on the other options also. Okay, so what are the Russell bodies? These are plasma cells. Plasma cells. What are these? These are collection of immunoglobulins. Now, these are also round and eosinophilic. These are also round and eosinophilic. Verrucate bodies. These are seen in neurilemoma, or we can say schwannoma. Civet bodies. Answer. Civet bodies are seen in which skin pathology? It is lichen planus. It is lichen planus. So these are Rushton bodies. These are tiny eosinophilic arc-shaped hairpin shape seen in the lining epithelium. Now these are the calcifications. Don't forget this. These are calcifications. Now what are Russell bodies? These are round eosinophilic. So something like this. These are round eosinophilic in which the nucleus which is present at the periphery of the cells, and these are collection of immunoglobulins. Now most commonly it is seen in multiple myeloma. Okay, so these are formed by plasma cells. These are collection of immunoglobulins. In multiple myeloma, these are called as Mott cells. So this is the basic difference between Rushton and the Russell bodies. So here the answer is Rushton bodies. Seen in the lining epithelium as discussed, linear arc-shaped calcifications, and these are called as Rushton bodies. Now these are refractile, very important point, okay, very important MCQ question. These are refractile but not birefringent. These are amorphous and brittle in nature. These can be curvilinear shaped, arc-shaped, eosinophilic shaped, C-shaped bodies, seen as calcification. Now, there is a one very important question associated with Rushton bodies. Now, where are these Rushton bodies are seen apart from the radicular cyst? So, these are seen in radicular cyst. We know that these are also seen in periapical granuloma. These are seen in dentigerous cyst. These are seen in OKC. Now, if in your question all these options are mentioned and if they have given all of the above, so we will mark all of the above. Okay. Now, if they have not mentioned all of the above, then we will give preference to the radicular cyst. Now, one again very important question associated with this. What is the source of these Rushton bodies? Now, some say it comes from the breakdown of the RBC due to hemorrhage into the cystic capsule. So whenever there is a hemorrhage occurs in the cystic capsules, these RBCs, they break down and they are seen as Rushton bodies. Or sometimes they are also seen as secretory product. Because they are seen as secretory product, it gives Rowley phenomena. So this is a very important point associated with Rushton bodies, that they give Rowley phenomena. Okay. Now, the next question. A filled maxillary tooth with class 5 composite restoration has a small mass near its cervical part. Okay. Biopsy shows squamous cells with individual cell keratinization. Now, this is not important part of the question. The most important part of the question is that the squamous cells, they have individual cell keratinization but no keratin pearls. Okay. So keratin pearls are not seen. Okay, so ऑप्शन तो ऐसे ही रूल आउट हो गए. ठीक है, केराटिन पल्स आर नॉट सीन. दैट मीन्स इट इज not the squamous cell carcinoma, because any squamous cell carcinoma will have the keratin pulse. So let's just have a look on the options. Basaloid squamous cell carcinoma. Okay. Moderately differentiated squamous cell carcinoma, early differentiated squamous cell carcinoma. Squamous odontogenic tumor is the option. Okay, is the right answer, because here the keratin pulse are not seen, but we see individual cell keratinization. Now, coming to the squamous odontogenic tumor. Now, what is the origin of these squamous odontogenic tumor? So, its origin is from rest of dental lamina, HERS stratum intermedium. Now, large island of squamous cells are present in the fibrous stroma. See, large island of these squamous cells are present in the fibrous stroma. Now, because it has an individual cell keratinization, it is very much similar to the acanthomatous ameloblastoma and squamous cell carcinoma. Now, as we have discussed, acanthomatous ameloblastoma में क्या दिखते हैं? We see squamous cells, right? Squamous cells are seen. And in squamous cell carcinoma, obviously squamous cells are present. So it is very much similar to the acanthomatous ameloblastoma and squamous cell carcinoma. Now, acanthomatous ameloblastoma, presence of squamous cells along with keratin pulse, but here the peripheral cells are ameloblast-like cells. So now how we will differentiate acanthomatous ameloblastoma and squamous odontogenic tumor? So in acanthomatous ameloblastoma, here the peripheral cells are tall columnar cells with hyperchromatic nucleus. But in squamous odontogenic tumor, we see cuboidal cells. We see cuboidal cells, not the tall columnar cells, and also here the keratin pearls are not seen. So this is the way how we differentiate acanthomatous ameloblastoma and squamous odontogenic tumor. And very most important point, no atypia, no mitotic figures, that all these malignant features are not seen here in the squamous odontogenic tumor. No inflammation, no palisading, no peripheral palisading of these cells are seen. Okay. So now one more important point here with respect to squamous odontogenic tumor, which is the most common location. So in maxilla, it is seen in incisor and the cuspid area, while in the mandible, it is seen in premolar and molar area. Okay. So this is important point, do not forget. Now coming to our next question, that a specimen which was sent from the oral surgery department labeled as periapical mass in the extracted tooth, which shows soft tissue rich in capillaries or the inflammatory cells. This shows feature consistent with, okay. So while you would have done your extraction in your final year, many times you would have come across this periapical mass. So your professors would have said ki, "Arey, this is periapical granuloma." Okay. So here the answer is periapical granuloma. Now here two options are slightly confusing. Okay, residual cyst and periapical granuloma. But in option, it has clearly mentioned there is soft tissue rich in capillaries and inflammatory cells. Okay, so the diagnosis is periapical granuloma. Now what is residual cyst? Residual cyst, it is basically a radicular cyst associated with an extracted tooth. Now, what happens when we are removing the radicular cyst? Some part of the pathology can still remain inside, and later it can develop into the residual cyst. But the histopath of the radicular cyst and residual, it is similar. Residual cyst, it is very much similar. So here the answer is periapical granuloma. Now this chart is very, very, very important. Okay, is very, very, very important. Okay, let's just have a look. Now, pulpitis. So, pulpitis occur as a result of bacterial cause or as a result of trauma. So, if this pulpitis, if it gets treated, then well and fine. If not treated, the chronic pulpitis will change into the apical periodontitis. Now, this apical periodontitis has two presentations, that is acute presentation and the chronic presentation. The acute presentation, the patient will come with you with a periapical abscess, now this periapical abscess, it can either, the patient can show acute presentation or the chronic presentation. Now in the acute presentation, the patient will come with the sinus which is present in the mucosa or the skin, while in the chronic it will undergo osteomyelitis. Same with your chronic apical periodontitis, it will have a periapical granuloma. Now if this periapical granuloma not treated, it will finally go into apical periodontal cyst, or also called as radicular cyst. And this periapical granuloma, it can also undergo osteomyelitis. Okay, so this is important, osteomyelitis from chronic periapical abscess and periapical granuloma. Now this osteomyelitis, it has a 4 presentations, that is, it can undergo cellulitis, that is different space infections it can involve, soft tissue abscess, and the chronic osteomyelitis, it can have many systemic involvements like bacteremia, septicemia. If it involves the cavernous sinus, it can lead to cavernous sinus thrombosis and it can undergo periostitis. So your many questions, you can solve 10 to 15 questions based on this chart. So this chart is very important with respect to your endo oral path. Okay, so the diagnosis is based on this chart. Okay, now coming to our next question, a forensic odontologist studied 7 left mandibular posterior teeth. Now which index or method is he using? Now here, okay, 7 left mandibular posterior teeth. Okay, so I know here in this options you can be confused between the Demirejans and the Kowal's method, because both are the radiographic method of determination of the age estimation. And in Kowal's tooth, which posterior teeth is used? 6 maxillary and mandibular. Okay, it is not 7, it is 6. 6 maxillary and mandibular teeth are used here. So here the answer is Demirejan's method. Why not Gustafson's? Because Gustafson's age estimation is slightly different. He used the different alterations of the tooth like atresion, secondary dentine deposition. We will have a look on that. Nola's method. So Nola's is also a radiographic method of age estimation. We will see the chart and you will be very clear on that. Okay. So Demirejan's method uses 7 mandibular posterior teeth for age estimation, while the Kowal's method uses 6 mandibular and maxillary teeth for the same. Now, Demirejan's method, so originally the third molar was excluded. Very important question. Very important question. The original method here, third molar was excluded, but in modified, it is included. Now, the important points associated with this is that in this Demirejan's method, the calcification of the teeth was divided into 10 stages. That is from 0 to 9. Okay, do not forget this. This is the 0 to 9, but all together there are 10 stages. There are not 9 stages, there are altogether 10 stages which is present, and these are numbered from 0 to 9. Now developmental stages, these are classified into 10 stages. For example, if 0, what is 0 represent? The tooth calcification is yet to begin. So I'll show you, see here in this. In 0, the tooth calcification is yet to begin. In stage 5, the crown is almost completed. Crown is completed, while in stage 9 the whole of the tooth is calcification is done. Okay, completion of the tooth calcification. Completion of tooth calcification. Now this is an important point here, that the Demirjian's method, he uses the radiographic method. Now based on the different developmental stages, he assigned a different score for each tooth. He assigned a different score for each tooth, and formula was used to calculate the age. Okay, so different formula was used to calculate the stage. Stage 5, crown completion. Stage 9, completion of the tooth calcification. Developmental stages was based on the radiographic assessment, and age was calculated by using some formula. Now, what is the Gustafson's method? And this is very important, Gustafson's method. So, he uses the regressive alterations of the teeth, such as A is attrition, S is secondary dentine deposition, P is periodontal attachment, loss of periodontal attachment, C is the cementum apposition, root resorption at the apex, and the next is the dentine translucency. So, this is very important. 1, 2, 3, 4, 5, 6. So based on this, age was calculated. Now this is the NOLA stage of NOLA's method of age estimation. Now in this, the only difference here is that this has a stage 10. Okay, so it is from stage 0 to stage 10. Do not get confused between Nolas and Demirjian's. Stage 10 has the apical foramen is closed here, okay? Not the total calcification of the tooth. Stage 10 here is apical foramen is closed. So you can take the screenshot of this chart. It is really important. This one and this one. Okay, this is the Demirjian's method. This is the Nola's method of age estimation. Okay. Now, coming to our next question. A 4-year-old child reported with early exfoliation of the deciduous teeth. So, here the teeth are exfoliating very fast. On examination, it was found that root apex was incomplete. Identify the condition. Now, tell me, in which deficiency, what deficiency of enzyme can lead to early exfoliation of the teeth? That means here the cementum is not getting deposited. Cementum deposition is affected. So, which enzyme level will get affected in this? It is ALP, that is alkaline phosphatase. So if we have a reduced level of alkaline phosphatase level, our cementum will not be formed, leading to the early exfoliation of the teeth. Now, which condition out of all this, which condition is associated with decreased alkaline phosphatase level? It is hypophosphatasia. So here the answer is hypophosphatasia. Now you guys tell me, increased alkaline phosphatase level is seen in which condition? It is seen in which condition? Now, let's just have a look on hypophosphatasia. So it is characterized by deficiency of non-specific alkaline phosphatase. Now what do we see here? In this, we see premature loss of primary teeth, presumably by a lack of cementum on the root surface. Now, there are 6 types of hypophosphatasia are seen, but out of these 6, 2 are very important. Okay. 6 types of hypophosphatasia are recognized. Now, depending on the severity and the age of the onset of these symptoms. Now, 2 types of hypophosphatasia, that is infantile and adult. Obviously, infantile, matlab it is occurring in this small babies. Obviously, it will have a more severe presentation. So, babies, they appear normal up to 6 months of the age, but after this time, they begin to show a failure to grow, and this is a very severe form. There is a premature loss of the teeth, and it is a severe deformation associated with the infantile hypophosphatasia. Now, in adult hypophosphatasia, it is a, obviously it will be a mild form. What do we see here? The patients here, they present with history of premature loss of the primary or the permanent dentition, or sometimes they also say that they are edentulous since the beginning. Now, coming to our next option, that is Shidak-Higashi syndrome. Shidak-Higashi syndrome. Now, this disease is characterized by immune deficiency. Matlab, here the patient is immunocompromised. So, what do we see in this immunocompromised patient? Oculocutaneous albinism, that is involvement of the eye, cutaneous, that is the skin, and the albinism. So, patients here, they present with easy bruisability. Why? Because here the platelet is affected. There is a decrease in amount of the platelet. Easy bruisability and bleeding as a result of deficiency of the platelet bodies. Recurrent infections are seen along with ulcerations on the oral mucosa, severe gingivitis, and a glossitis along with periodontal breakdown. Okay, so now coming to our next oral manifestation, that is leukemia. Okay, leukemia. So what do we see in leukemia? So you would have done this in your perio lectures. Okay, so leukemia. So what do we see here? Diffuse, boggy, non-tender swelling kind of presentation in the oral soft tissue that may or may not be ulcerated. Now, which is the most common type of leukemia which is seen in the oral cavity? It is the myelomonocytic type of leukemia. And the patients, they present with diffuse gingival enlargement and a prominent tumor-like growth which is seen in the gingiva. It is called as scleroma. It is a very important MCQ question. Okay. Now coming to the histiocytosis. Tell me, which is a radiographic feature associated with histiocytosis? So in histiocytosis, we see multiple punched out radiolucency, and it also has severe destruction of the periodontal tissue. So resulting bone destructions and loosening of the teeth clinically may resemble as severe periodontitis. Now, the diagnosis of hypophosphatasia is based on 2 things. One is the alkaline phosphatase level. Okay, their phosphatase level is reduced, and also on the basis of phosphoethanolamine. Okay, so based on clinical manifestations and the findings of decreased level of serum alkaline phosphatase level and increased amount of phosphoethanolamine in both urine and the blood. Very important point. Sometimes what happens, you tend to forget phosphoethanolamine, and this plays a major role in the diagnosis. Okay, so do not forget this. With respect to your MCQ question, this is also important. Now, which statement is not true regarding carcinoma of lip? Now, I am saying that this is a very controversial type of question. But since it has been asked in your previous paper, what we do in MCQ, we will rule out the options. Okay, so let's just rule out all the options here. Now, mostly occur on the lower lip. Obviously, carcinoma of the lip, it will usually occur on the lower lip. Metastasizes early. Okay, we will see lateral spread and usually noticed early. So, carcinoma of the lip, obviously, everyone will, it will get noticed very fast. So, here the right option is metastasizes early. Now, why I am saying this? If it is getting noticed early, obviously, it will get treated fast. If it is getting treated fast, obviously it will not get much time to metastasize. Okay, so here this is how we solve MCQs in this controversial type of questions. So here the answer is metastasizes early. So, squamous cell carcinoma of the lip has good prognosis as it getting detected early. Metastasis is a late event because most lip vermilion carcinomas are diagnosed at an early stage. Now, here a very important MCQ question, that the overall 5-year relative survival rate here is excellent, that is approximately 95%. Okay, so answer here is metastasizes early. Now, our last question of the today's session, that a young child presents with hypertelorism, hypoplastic maxilla, brachycephaly, propoptosis. The lateral cephalogram shows all the features as below. What is the diagnosis? See here. This is the lateral cephalogram. Even if you don't remember hypertelorism, hypoplastic maxilla, brachycephaly, all that. See, in the lateral cephalogram, we can see which appearance is this? It is a copper beaten metal appearance. Copper beaten metal appearance. So, copper beaten metal appearance is seen in which condition? It is Clausen's syndrome. It is Clausen's syndrome. I think this is a very direct question. Okay. Even if you don't remember hypoplastic maxilla, brachycephaly, propoptosis, but still with this radiographic image, you can solve this question. Now, the Treacher-Collins syndrome and mandibulofacial dysostosis, it is both are same. Okay, both are same. Now, this is a Clausen syndrome. Now, what we can see here? Hypoplastic maxilla, that is mid-face hypoplasia, along with mandibular prognathism, propoptosis of eye, hypertelorism, and short head. Short head. So, craniosynostosis. What is craniosynostosis? That is premature closure of the cranial sutures. Brachycephaly. So there are three important points: brachycephaly, scaphocephaly, and trigonocephaly. Brachycephaly means short head. Scaphocephaly, that means boat shaped head, and trigonocephaly, that means triangular shaped head. Now, here the ocular propoptosis is seen along with the skull radiograph, which shows the copper beaten metal appearance, giving the right answer as Clausen's syndrome. Here the maxilla is underdeveloped, leading to mid-face hypoplasia. Now, which is the other name of Treacher-Collins syndrome? Treacher-Collins syndrome, it is also called as mandibulofacial dysostosis. Now, see, if you tend to forget that Treacher-Collins syndrome किस आर्ट से form होता है, just remember it other name, mandibulofacial dysostosis. So which mandible is formed from which arch? It is the first and the second brachial arch. So it is characterized by defect from the first and the second brachial arch. What is coloboma? That is outer portion of the eyelid is depressed. So this is coloboma along with the ear anomaly seen in the Treacher-Collins syndrome. And which is the gene associated? TCOF, one gene mutation associated with Treacher-Collins syndrome. Now, cleidocranial dysplasia में क्या होता है? There are dental anomalies along with the clavicular anomalies. So here the clavicles might be hypoplastic, discontinuous, or sometimes it can be even absent. It can be absent. Now, what are the additional features? That is short stature, enlarged skull, brachycephaly is seen here, along with pronounced frontal and the parietal bossing, along with ocular hypertelorism. Now, this is a very important chart, okay? So, you guys can take a picture of this, okay? And you can paste it anywhere on the wall so that it will be easier for you to recall. So, cleidocranial dysplasia. The patient is having large skull, frontal and parietal bossing, brachycephaly, that is short head, ocular hypertelorism, nose with depressed bridge, that is the saddle nose, delayed closure of the sutures, Vermian bones. So Vermian bones, these are small bones which are not fused properly at their time. Small or absent paranasal sinuses, narrow high arched palate. Sometimes the patients, they may present with cleft palate, and there are many supernumerary impacted teeth may be present in the cleidocranial dysplasia. Now, there's one important point associated with cleidocranial dysplasia, that which growth factor is deficient in this, mutation of which growth factor. So it occurs as a result of mutation of fibroblast growth factor 2 receptor present on the chromosome 10q26. So this finishes your most important NEET questions. Okay, so we will have many such sessions. It is more of a revision based session at this point of time. It is more of a revision based session. So by this, looking at the different questions, we will finish our different topics also. So everybody, bestest of luck. Bestest of luck.